Welcome back to the deep dive, where we take your source materials, your notes, your textbooks, and we perform a high-altitude distillation, turning dense knowledge into crystal clear, clinically relevant insight. Today, we are strapping in for a deep dive into one of the most vital, immediate, and I'd say high-stakes areas of acute care: advanced concepts of respiratory care.
Really is.
So if you are a clinician prepping for a critical care rotation, maybe trying to master the nuances of ventilatory failure, or, just intensely curious about the mechanics of life support, this one is tailored specifically for you. We've collected a massive stack of source material here, and we're planning to move far beyond just basic anatomy. We're going to cover everything from interpreting those really subtle shifts in bedside monitoring to managing severe progressive conditions like ARDS and complex chest trauma.
And that's the critical distinction we need to make today.
Yeah.
Our mission really is to move past a simple review of pathology.
Right.
We're focusing heavily on the critical nursing assessment, what you see, what you hear, and what you feel at the bedside.
The hands-on stuff.
Exactly. And how that immediate data dictates rapid life-saving interventions and, just as importantly, the crucial patient teaching that's needed for recovery. We have to understand the core physiological mechanisms, particularly how gas exchange works, and why a VQ mismatch can be so catastrophically difficult to fix.
Just so setting the stage clinically.
We need to set the clinical context immediately.
Yeah.
Respiratory failure, it isn't a single disease. It's a devastating condition that results from inadequate gas exchange.
Yeah.
So we're dealing with two distinct problems that, often overlap.
Okay.
Either you have insufficient oxygen transfer to the blood, that's hypoxemic failure, or you have insufficient carbon dioxide removal, and that's hypercapnic failure.
And the whole roadmap depends on knowing which one it is.
The entire therapeutic roadmap, whether we use BiPAP, high-flow nasal cannula, or proceed to invasive ventilation, it all hinges on correctly using precise diagnostic data, primarily the arterial blood gases, to distinguish which failure mode is dominant.
Okay, so let's unpack this crucial information by starting right where it all begins, at the bedside. Before we even get to the high-tech machinery, the very first line of defense is just the sharp anticipatory assessment skills of the critical care nurse. The foundational assessment, it starts with those four core components, right? Vital signs, inspection, palpation, and auscultation. When we talk about inspection, the sources really emphasize looking beyond just the respiratory rate. It's about the quality of the effort.
Oh, absolutely.
Yeah.
Inspection gives you instantaneous data on distress. We're not just logging a number between, say, 12 and 20 breaths per minute, which is the textbook normal.
Right.
But we're watching for tachypnea, for the use of accessory muscles, tripod positioning, and just the overall rhythm.
And the sources mention something specific about older patients.
Yes, and this is critical context. The sources highlight that in older persons, the upper limit of normal is actually higher, often up to 25 breaths per minute. Missing that shift can lead to, well, under-recognition of early distress in the geriatric population. You can miss something big.
And what truly signals a major system collapse are those abnormal patterns. We can assume our listeners know the basics, so let's focus on the clinical significance. What do these patterns tell you?
Okay, let's look at Kussmaul's. This is a rapid, deep, labored pattern. It's the body's compensatory response to severe metabolic acidosis. It's trying aggressively, desperately, to blow off acid in the form of Q-Row.
So you see that and you're immediately thinking DKA.
DKA or another metabolic emergency, exactly. Then you have Cheyne-Stokes, which is that highly unstable pattern of alternating periods of deep, rapid breathing followed by apnea that almost always points to significant CNS involvement.
Like a brain injury.
Often brain injury, heart failure, or even a drug overdose. It reflects a critically unstable respiratory drive from the brain itself.
And what about Biot's respiration? That one always seemed more chaotic.
It is. Biot's is highly alarming. It's these irregular bursts of respirations of varying depth, maybe 3 or 4, separated by unpredictable periods of apnea. Because it's so irregular, it often signals damage at the medullary level.
So high-level neurological insult.
Exactly. Infection, severe pressure. The nursing action here is immediate, aggressive neurological and respiratory support, recognizing that full respiratory arrest could be imminent.
Okay, moving on from observation, let's talk about palpation. This is where we determine symmetry, which I think is often an unsung hero of the initial physical exam.
It really is. Palpation assesses the symmetry of chest expansion. You place your hands on the back or the front of the chest, and you just watch how they separate on inspiration.
And if they don't separate equally...
If the expansion is asymmetrical, it means air entry is limited on one side. This is a crucial rapid differential diagnostic tool. I mean, The limitation could be mechanical, like a atelectasis causing a restricted airless area,
Or something more dramatic.
or something much more dramatic, like a large pneumothorax where air has collapsed the lung, or, it could be as simple as severe incisional pain, or a rib fracture where the patient is self-splinting and just refusing to take a deep breath.
And the nursing intervention for that last one is key.
It is. For the pain, the intervention is pain management that's sufficient to restore symmetrical, deep breathing without causing respiratory depression. It's a fine line.
That's the key. It's not just a finding, it's an intervention trigger. Okay, finally, let's explore the soundscape. Auscultation. For an advanced listener, we need to focus on the nuances that differentiate these sounds.
Absolutely. Differentiating adventitious sounds is a core competency. Let's start with crackles. They're generally non-continuous, short, popping sounds. But we need to differentiate between fine crackles.
Like hair rubbing together.
Exactly. Often heard in pulmonary edema or interstitial disease. And then you have coarse crackles, which are louder, longer, lower pitched. Those are often associated with thick, copious secretions.
And those might clear with coughing.
Right. The coarse ones often resolve with coughing or suctioning, which is an immediate nursing intervention check right there.
Okay, what about wheezes?
Wheezes are continuous, high-pitched squeaking sounds that happen primarily on expiration. They tell you the airways are narrowed from bronchospasm or edema.
But there's a critical pearl here, right?
There is, and it's a huge one. If a patient is severely asthmatic or in status asthmaticus and the wheezes suddenly disappear, that's a catastrophic sign.
The silent chest.
The silent chest. It means near complete airway closure and impending respiratory arrest. That demands immediate intubation prep.
Wow. That's a powerful clinical pearl. The absence of sound is worse than the sound itself. And the third sound, the pleural friction reb. What makes this one so specific?
The rub is a very distinctive creaking or grating sound, and it's classically heard during both inspiration and expiration. What makes it a gold standard diagnostic marker is that it originates outside the bronchial tree.
It's the pleura itself.
It's the roughened, inflamed surfaces of the pleura rubbing together, which is pleurisy. And crucially, unlike those coarse crackles from secretions, the pleural friction rub does not change or clear with coughing.
So that lets you differentiate immediately.
It allows the nurse to rapidly differentiate a simple secretion problem from a significant inflammatory process like pleurisy, pneumonia, or even a pulmonary infarction.
Okay, now, let's talk about a more formal mapping tool for the mechanics of lung function, pulmonary function tests, or PFTs. While the nurse doesn't perform them, interpreting the results is absolutely foundational for chronic disease management and critical care planning.
Right. PFTs measure dynamic and static lung volumes, and they help us primarily diagnose and monitor pulmonary disease. But more importantly in this context, they let us differentiate between restrictive and obstructive disorders.
And they can assess response to treatment.
Exactly. They're also used to assess the effectiveness of bronchodilator therapy.
The source notes the key measurements: tidal volume, vital capacity, minute ventilation. But for the advanced learner, why is the FEV1-FEC ratio the critical measure here, especially for obstructive disease?
The FEV1-FEC ratio is really the cornerstone of differentiation.
Yeah.
FEV1 is the forced expiratory volume in 1 second, and FEC is the forced vital capacity, the total amount of air you can exhale after a maximal breath in. In obstructive disorders like COPD, asthma, bronchiectasis, the patient struggles to get air out quickly because of those narrowed airways. So the FEC might be nearly normal, but the FEV1 drops significantly.
So the ratio plummets.
Precisely. A hallmark criterion for obstruction is an FEV1-FVC ratio that's less than 70% of the predicted value.
And for restrictive disorders?
Conversely, in restrictive disorders like pulmonary fibrosis or chest wall deformities, the lungs are stiff and they just can't expand. So the FEV1 and the FVC both decrease proportionally, meaning the FEV1-FVC ratio often remains normal or can even be high.
So understanding that ratio tells you where the problem is.
It tells you exactly where the primary mechanical problem lies. Is it getting the air out or is it getting the air in? And that distinction dictates entirely different management strategies.
That leads us straight into the core physiological problem in acute respiratory failure, the ventilation-perfusion, or VQ relationship. This relationship, the matching of airflow to blood flow, defines how effective gas exchange can be.
It really does. The optimal ratio is about 0.8. A slight mismatch is normal. You've got about 4 liters of air meeting 5 liters of blood per minute. But when this match breaks down, it is the overwhelmingly common cause of hypoxemia, or low oxygen levels.
So let's start with the most severe mismatch. Low VQ or shunt. What is the physiological fallout from that?
A low VQ, occurs when the alveoli are perfused. So blood flow is good, but they're not ventilated. Air is absent. The ratio approaches zero.
So V over Q is almost zero.
Exactly. This is the definition of an intrapulmonary shunt. Blood is flowing through the pulmonary capillaries without participating in gas exchange at all. It returns to the left heart just as deoxygenated as it left the right heart.
And the clinical significance of that is massive.
It's profound. Shunts cause severe hypoxemia because the blood simply cannot access the oxygen. Common causes are these alveolar filling processes, widespread atelectasis, severe pneumonia, or pulmonary edema.
And there's a key feature of shunt-induced hypoxemia.
There is. The crucial nugget here is that it's often refractory to supplemental oxygen. If you put a non-rebreather on a patient with a 30% shunt, the oxygen you're giving only goes to the ventilated lung units, not the collapsed or fluid-filled ones.
It's just not getting to where it needs to be.
It can't. The sources emphasize that shunting greater than 15% of cardiac output constitutes severe respiratory failure, which demands mechanical ventilation and PEEP to physically open those collapsed units.
And the other side of the coin is the high VQ, or dead space. This is just wasted ventilation.
Precisely. High VQ means the alveoli are ventilated, they're full of air, but they are not perfused because the blood flow is blocked. The ratio approaches infinity.
4 divided by 0.
Right. And that air, which never participates in gas exchange, is termed alveolar dead space. It's wasted effort.
And the classic example here is a PE.
The classic life-threatening example of high VQ dead space is a pulmonary embolism. A clot blocks the pulmonary artery, stopping perfusion distal to that blockage. The air is completely wasted.
So what does that do to the blood gases?
Well, the resulting hypoxemia triggers massive reflexive hyperventilation. And that often leads to a paradoxical finding in early PE, a low PACO, so respiratory alkalosis, alongside the hypoxemia. This is a crucial distinction for the critical care nurse to interpret.
Okay, let's be practical. Are these VQ mismatches always so pure? Or do we often see a mixed picture in the real world?
Oh, you almost always see a mixed picture. A patient with severe pneumonia, which is a low VQ problem, might also have a degree of atelectasis, also low VQ. But they may also experience pulmonary vasoconstriction secondary to inflammation, which functionally creates areas of higher VQ.
So you have to treat the dominant problem.
The nurse's primary intervention is always to address the dominant component, which is usually the shunt. So things like high flow oxygen, positioning, often prone in severe cases, and if needed, positive end expiratory pressure, or PEEP, are all geared toward recruiting those collapsed airless alveoli to improve that VQ matching.
Okay, now let's move to the critical diagnostic trio that gives us continuous real-time feedback on how successful those interventions are, starting with the absolute foundation, arterial blood gases, or ABGs.
ABGs are the definitive measurement. A critical care clinician has to have these normal values just internalized. pH 7.35 to 7.45, PACO 35 to 45, PACO 80 to 100, and bicarb 22 to 26.
And the definition of acute respiratory failure is based on these numbers.
Entirely. The definition for acute respiratory failure, ARF, is based on these numbers. PACO greater than 50, a pH less than 7.3, and/or a PAO less than 60. Hitting any of those criteria demands immediate aggressive intervention.
Moving to non-invasive monitoring, pulse oximetry SpO2 is universal, but it's notorious for being misleading in high acuity settings. What are the key limitations the nurse has to actively mitigate?
Right, SpO only measures hemoglobin saturation. It is a lagging indicator and it's highly susceptible to artifact, so we must be vigilant about conditions that affect the signal.
Like movement.
Excessive movement, for sure, that gives you motion artifact. Also vasoconstriction, whether from shock, cold, or vasopressors, and any low perfusion state like hypovolemia or hypothermia.
So what's the nursing takeaway?
The nursing takeaway here is that if the patient looks poor, but the SpO is 95%, you check the perfusion at the probe site. If the pulse tracing is weak or irregular, you move the probe or use an ear or forehead probe. And more importantly, it can be wildly inaccurate in carbon monoxide poisoning because cohemoglobin is read as oxygenated hemoglobin, and also in the presence of methemoglobinemia. Always treat the patient, not the machine.
This brings us to the truly advanced bedside monitor, end-tidal CO2, ETCO2, or capnography. This gives us real-time data on the effectiveness of ventilation, and it is far more sensitive to changes in co-euro removal than SpO euros is to O saturation. The normal range is what, about 30 to 43?
That's right, 30 to 43 mmHg. At TTO2 measures the partial pressure of co-euro at the very end of exhalation, that peak plateau. In a healthy person, this closely mirrors the arterial co-euro. The key strength is that it's a direct indicator of both alveolar ventilation and pulmonary perfusion.
The sources provide a huge list of specific nursing indications for EdTCO2. Let's focus on the most critical, life-saving uses.
Okay, first and foremost, EdTCO2 is the fastest way to confirm endotracheal tube placement immediately post-intubation. A lack of co-Euros means the tube is likely in the esophagus. It's a game changer.
And for sedation.
Secondly, during procedural sedation or opioid administration, like with a PCA pump, EdTCO2 will detect early respiratory depression, arising EdTCO minutes before hypoxemia causes the SABU to drop.
Yeah.
This is the difference between a near miss and a full-blown code situation.
And its role in CPR is also critical.
Thirdly, yes, and crucial for critical care, it's a direct indicator of cardiac output during CPR. A low EdTCO, say, below 10 to 15, suggests inadequate chest compressions because co-Euro is not being delivered to the lungs to be exhaled.
So if it spikes,
If EdCO suddenly spikes during CPR, it often signals return of spontaneous circulation, ROSC. That makes it a powerful prognostic and procedural tool.
but we have to acknowledge the limitations of EdTCO2, especially in shock states. This is where the advanced knowledge really comes in.
Absolutely. The difference between the arterial key euro, PECO, and the end tidal, co-euro, ETICO, is called the PAET key euro gradient. If a patient is in severe uncompensated shock, so hypoperfusion, there might be a lot of dead space, that high VQ mismatch.
So blood isn't getting to the alveoli.
Right, blood isn't reaching the alveoli to offload C euro. In this scenario, the ETICO-euros can be misleadingly low, maybe 20 millimilli Hg, even if the patient's actual arterial pancoeuro is normal or high, say 40 millimilli Hg.
So what's the nursing action?
The nursing action is not to simply accept the ETICO reading, but to correlate it with the patient's perfusion status and recent ABGs. It's a reminder that in severe shock, that gradient widens dramatically.
Okay, let's synthesize this monitoring data into the two distinct failure modes we mentioned earlier.
Right. So first, hypoxemic failure, or failure to oxygenate. The core problem here is VQ mismatch, or shunting, where the PIO is low, less than 60, despite aggressive oxygen therapy. This requires strategies to recruit alveoli and improve diffusion.
And the other side?
Hypercapnic failure, or failure to ventilate. Here, the core problem is insufficient co-euro removal, leading to alveolar hypoventilation. It's defined by a PACO-euro greater than 45 with a resultant acidosis, so a pH less than 7.35. This requires strategies that improve the mechanical pump, often through non-invasive or invasive mechanical ventilation to increase minute ventilation.
And understanding this distinction is not just academic. It dictates whether you're primarily focusing on PEEP and FiO-Euro for oxygenation or tidal volume and respiratory rate for ventilation.
It dictates everything.
Okay, let's pivot now to the most challenging catastrophic manifestation of hypoxemic respiratory failure, acute respiratory distress syndrome, or ARDS. The source defines it as a sudden, progressive failure resulting from damage to the alveolar capillary membrane.
It is the ultimate presentation of uncontrolled inflammation in the lungs. The damage makes the membrane permeable, leading to what we call non-cardiogenic pulmonary edema.
So fluid leaking out because of injury, not because of heart failure.
Precisely. And this causes profound stiffness or reduced lung compliance, overwhelming dyspnea, and the defining characteristic, hypoxemia, that is refractory to supplemental oxygen. Sepsis remains the leading cause that triggers this whole inflammatory cascade.
And the pathophysiology centers on this massive neutrophil infiltration and mediator release. What are the specific destructive outcomes of this inflammatory storm?
The storm is multifaceted. First, you have a dramatic increase in capillary permeability, which causes all that alveolar flooding. Second, the release mediators and enzymes destroy the structural integrity of the lung, the elastin and collagen, which contributes to the stiffness.
It's a structural problem, too.
It is. And third, you see pulmonary microemboli and widespread pulmonary vasoconstriction, which further increases dead space and drives pulmonary hypertension. All of this just decreases the available surface area for gas exchange and dramatically reduces the lung's elasticity.
To manage ARDS, the nursing and medical teams have to anticipate its chronological progression through 3 phases. Let's detail the first one, the injury or exudative phase.
This happens fast, typically within the first week of the initial insult. Neutrophils cause the injury, fluid leaks out, and you get interstitial edema, alveolar flooding, and massive intrapulmonary shunting.
And what about surfactant?
Crucially, the damage extends to the type 2 alveolar cells, which are the cells responsible for producing surfactant.
So without surfactant?
Without adequate surfactant, the surface tension inside the alveoli increases, and that causes widespread alveolar collapse, or atelectasis. This collapse makes the lungs incredibly stiff, severely decreasing compliance. The nursing relevance is immediate. The patient will require very high airway pressures during mechanical ventilation to move any air.
And that leads to the hallmark sign.
It leads to the hallmark sign of this phase, rapidly worsening refractory hypoxemia.
So if the inflammation isn't halted, we move into the structural reorganization of the reparative or proliferative phase.
That's right. This begins about 1 to 2 weeks post-injury. The body starts laying down fibrous tissue in response to the ongoing inflammation. Fibroblasts proliferate, causing the lungs to become even stiffer.
And that makes the hypoxemia worse.
It does because this fibrosis thickens the alveolar capillary membrane, worsening hypoxemia due to what we call diffusion limitation. The outcome at this stage is highly variable. Aggressive management is really aimed at reducing that inflammation to prevent permanent scarring.
And the final chronic and most debilitating stage, the fibrotic or chronic elite phase.
This occurs 2 to 3 weeks after the initial injury. This phase is defined by extensive irreversible remodeling and scarring. Normal lung tissue is replaced by dense, non-compliant fibrous tissue.
And the outcome here is pretty grim.
It results in the most marked decrease in compliance, persistent, severe dependence on high oxygen support, and often the secondary development of severe pulmonary hypertension due to the destruction of the pulmonary vasculature. Long-term dependence on oxygen and limited functional capacity are, unfortunately, common outcomes.
The overall goals of ARDS management are clear. Identify and treat the root cause, support the patient, and, most critically, prevent iatrogenic complications. So let's focus on the interprofessional and nursing management required for this very complex patient population.
The cornerstone of support is something called lung protective ventilation, or LPV. Because the lung is so fragile, we have to avoid further injury from pressure, which is barotrauma, and volume, which is volley-trauma.
So how do you do that?
This means using low tidal volumes, around 6 LAL per kilogram of predicted body weight, which is significantly lower than normal ventilation settings. The nurse's role is continuous monitoring to ensure the plateau pressure, that's the pressure exerted on the alveoli, remains below 30 centimeters of water, signaling that the lungs are not being overdistended.
That low tidal volume strategy is absolutely critical for preventing ventilator-associated lung injury. But how do you manage the persistent hypoxemia that comes with that strategy?
That's where PEEP, or positive inexpiratory pressure, comes in. We use PEEP to physically force open the collapsed alveoli and keep them open, which reduces the shunt.
But there's a balance to be struck.
A very delicate balance. The goal is to balance PEEP with the risk of causing barotrauma, or, critically, reducing venous return and subsequently decreasing cardiac output. This requires constant hemodynamic monitoring via arterial lines and central venous catheters.
Which dovetails perfectly into the nursing priority of optimizing hemodynamics and fluid balance.
Exactly. Since ARDS involves leaky capillaries, we have to restrict fluids. We actually aim for a negative fluid balance, or, at a minimum, a euvolemic state. Daily weights, strict I's and O's, and minimizing fluids while maintaining perfusion, often with judicious use of vasopressors, are key.
So you want to keep the lungs dry.
You want to keep the lungs as dry as possible without causing global tissue hypoperfusion.
Let's discuss one of the most drastic but often life-saving interventions: prone positioning. Why is turning a critically ill patient face down so effective in severe ARDS?
Prone positioning is a physiological intervention based on gravity. In the supine position, the weight of the heart and the chest compresses the dependent or posterior lung tissue, which just worsens atelectasis and shunting.
So when you flip them over?
When the patient is prone, this weight shifts. It redistributes air and blood flow to those previously compressed posterior segments, recruiting more functional lung units. This improves VQ matching and oxygenation, sometimes dramatically.
And the nursing responsibility here is immense.
It is. It requires meticulous coordination. We have to manage the ET tube and all the lines, arterial, central feeding to prevent dislodgement. We have to manage skin integrity, especially on the face and the anterior chest, and ensure proper eye care. It's a high-stakes, multi-person intervention managed hour by the nursing team.
And finally, in the most severe refractory cases, we often see the use of neuromuscular blocking agents, or NMBAs. What's the rationale there, and what is the nursing burden that comes with it?
NMBAs, like cisatracurium, are used to achieve complete muscle paralysis. The rationale is to eliminate the patient's own spontaneous breathing efforts and reduce oxygen consumption. It allows the ventilator to fully control the fragile lungs and ensure that low tidal volume strategy is precisely maintained.
But the nursing burden is huge.
It is significant. The patient is completely paralyzed, but not necessarily sedated unless specific agents are given. So the nurse must ensure profound, continuous sedation and analgesia, usually with propofol and fentanyl or Mediolum drips, to prevent awareness.
That's terrifying to think about.
It is. They also have to manage eye care with lubrication and taping to prevent corneal abrasion, prevent nerve compression injuries from lack of movement, and provide frequent passive range of motion exercises to minimize muscle wasting. It is one of the highest acuity patients you can have in the ICU.
Okay, let's move down the continuum of support, starting with some foundational airway management devices. We can assume our listener knows the basics of OPA and MPA placement, so let's focus on the hard and fast contraindications and the critical nursing assessment steps.
Exactly. The OPA, or oropharyngeal airway, is a rigid tool for the unconscious patient with an absent gag reflex. And the contraindication is absolute. Never insert it if the patient is semi-conscious or has an intact gag. It guarantees vomiting and aspiration.
And sizing is key.
Sizing is critical. If it's too large, it can include the larynx. If it's too small, it just pushes the tongue back, worsening the obstruction.
Okay, what about the MPA?
The NPA, or nasopharyngeal airway, is for conscious or semi-conscious patients or those with oral trauma who still have a gag reflex. The critical contraindication, which must be immediately ruled out in trauma, is a basilar skull fracture or severe nasal or facial trauma.
Because you could end up in the brain.
You risk misdirection into the cranial vault. We use the tip of the nose to earlobe measurement for sizing, and the nursing responsibility is meticulous. Ensure proper lubrication and select the correct patent nostril.
Moving up to non-invasive ventilation, NIV, CPAP, and BiPAP. The crucial prerequisite here is that the patient must be capable of initiating spontaneous breathing.
Right. NIV avoids the complications of invasive support, like VAP or tracheal damage, and it's ideal for specific conditions. Let's clarify the pressure mechanics and the indications for each.
Let's start with CPAP.
Okay, CPAP, or continuous positive airway pressure, delivers one set positive pressure during the entire respiratory cycle. It primarily functions as PEEP, keeping the alveoli open and thus improving oxygenation.
And it's great for sleep apnea.
It's the gold standard for treating obstructive sleep apnea, and it's also highly effective in treating acute cardiogenic pulmonary edema because that continuous pressure helps push fluid out of the alveoli.
And BiPAP, or bilevel positive airway pressure, adds a layer of ventilatory support.
It does. BiPAP provides two pressures, a higher pressure on inspiration, which we call IPAP, and a lower pressure on expiration, which is EPAP. The IPAP provides a pressure boost, helping the patient increase their tidal volume and blow off co-uros. The EPAP acts as PEEP, aiding oxygenation.
So BiPAP is for CO2 problems.
Because BiPAP actively assists ventilation, or co-uro removal, it is the preferred mode for treating hypercapnic respiratory failure, which you typically see in COPD exacerbations or in patients with severe neuromuscular weakness.
The nursing role in NIV seems to be dominated by vigilant monitoring for complications. What are the key areas of concern?
Oh, definitely. The interface itself causes problems. You have skin breakdown on the bridge of the nose, which necessitates frequent assessment and prophylactic dressings. You get gastric distension from air being pushed into the stomach, which increases aspiration risk.
And mask leak.
If the mask fit is poor, air can leak into the eyes, causing conjunctivitis. The nurse also has to manage the patient's anxiety, which is often profound due to that feeling of air being forced at them. We also monitor etiquette continually to ensure the NIV is actually improving ventilation, not just masking hypoventilation.
And the absolute contraindications for NIV are critical. When do you bail and decide to intubate?
NIV requires a stable patient who can protect their own airway. So if the patient has unstable hemodynamics, severe dysrhythmias, if they're apneic, if they can't manage their own copious secretions, or they have severe nausea and vomiting, NIV is just dangerous.
And if it's just not working?
Exactly. If we cannot gain a proper mask seal, or if the patient simply fails to improve on NIV after a short trial, we proceed to invasive mechanical ventilation.
That brings us to invasive mechanical ventilation, MV, via an endotracheal tube. Indications include apnea, failure to maintain or protect the airway, or persistent ARF. The nursing responsibilities during the rapid sequence intubation procedure are complex.
The nurse is absolutely the lifeline during intubation. Pre-procedure, this means ensuring IV access, gathering all the necessary equipment, the ETT, stylet, BVM, suction medications, and administering the required sedatives and paralytics for RSI, precisely and safely.
And after the tube is in,
Post-procedure, immediate confirmation of placement is paramount. First with echo, which should turn yellow or read a cohere waveform, and then with auscultation and a chest X-ray.
Once secured, nursing management shifts to rigorous maintenance. Beyond monitoring continuous O and co-euro levels, what are the daily high-priority tasks?
Maintenance involves confirming the tube depth at the lip or gum line and ensuring adequate cuff inflation pressure, typically 20 to 25 centimeters of water to prevent aspiration while avoiding tracheal ischemia.
And suctioning?
And tube patency requires aggressive suctioning, but suctioning itself can cause hypoxemia and elevated intracranial pressure, so it has to be done only when indicated, like visible secretions, raunchy, or high peak pressures on the ventilator.
A cornerstone of prevention and a major focus of our source material is the VAP Prevention Bundle. These are mandatory, specific nursing interventions.
The VAP bundle is evidence-based medicine executed by the bedside nurse. It includes 4 key elements. First, head of bed elevation, maintaining the head of the bed at 30 to 45 degrees to prevent reflux and aspiration.
And oral care.
Meticulous oral care, often using specialized antiseptic agents like chlorhexidine to reduce the bacterial load in the oropharynx. Third is a daily sedation interruption, or an SBT screen, to assess the patient daily for readiness to wean and extubate, because only your extubation reduces VAP risk.
And prophylaxis.
Right, peptic ulcer and DVT prophylaxis. Yep. Though often physician-ordered, the nurse ensures timely administration of these preventive meds. Adherence to this bundle saves lives and reduces hospital stay length.
Finally, what are the major high-stakes complications of MV that the nurse must continuously monitor for?
There are 2 main categories: airway and mechanical. Airway first. Accidental extubation is life-threatening. The nurse has to immediately re-ventilate with a BVM. Mechanical risks include barotrauma or volutrauma, which can lead to a pneumothorax if excessive pressures cause an air leak.
And how would you spot that?
That's signaled by sudden high peak pressures on the vent and deteriorating oxygenation.
And what about systemic effects?
The final complication is systemic. Decreased cardiac output. Positive pressure ventilation increases intrathoracic pressure, which impedes venous return to the heart. This can drop the blood pressure and cause shock. The nurse has to monitor hemodynamics continually and collaborate immediately to adjust PEEP or volume status if the cardiac output falls.
Okay, let's look at some specific acute respiratory challenges, starting with chest trauma, which requires instant recognition and response. We categorize it as either blunt or penetrating. The immediate threat, beyond the injury itself, is often a pneumothorax.
Right. A pneumothorax is air in the pleural space, causing a partial or full lung collapse. We assess for 3 main types in a trauma setting. There's closed, which is spontaneous, often due to a bleb rupture or non-penetrating trauma. There's open, which is a sucking chest wound where air is entering from an external opening. And then there's the absolute emergency, tension pneumothorax.
Let's detail the rapid progression of a tension pneumothorax, as timely nursing action here really determines survival.
It does. A tension pneumothorax is when air accumulates rapidly in the pleural space and it cannot escape. This high pressure compresses the lung and it shifts the mediastinum, the heart, great vessels, trachea toward the unaffected side.
And that causes obstructive shock.
It severely impedes venous return and cardiac output. The patient rapidly progresses from severe respiratory distress to tachycardia, profound hypotension, and jugular venous distension. The late classic sign is that tracheal deviation to the unaffected side.
And you can't wait for that sign.
No. Nursing assessment have to recognize the early signs, the severe distress and hypotension, because the definitive treatment is immediate decompression, which requires a rapid needle venting by the physician or advanced practitioner. Every single minute counts.
For an open pneumothorax or a sucking chest wound, the immediate nursing intervention is unique and critical.
It is. The intervention is to prevent air from entering the chest cavity during inspiration while still allowing trapped air to escape during expiration.
So you create a one-way valve.
You achieve this by covering the wound with an occlusive dressing secured on 3 sides only. This creates a one-way flutter valve. If you tape all 4 sides, you convert it into a closed pneumothorax, risking the rapid development of a lethal tension pneumo.
Shifting to structural injuries, fractured ribs are the most common chest injury, often involving ribs 5 through 10. The nursing challenge is pain control without respiratory suppression.
Pain management is the absolute core of the care plan. The pain causes the patient to involuntarily self-splint and take shallow breaths, hypoventilation.
And that leads to atelectasis.
It immediately leads to the complication of atelectasis and subsequent pneumonia. Our primary goal is aggressive pain management to restore chest wall motion and promote deep breathing.
How do you manage that?
Interventions include careful, individualized administration of analgesics. We have to use opioids cautiously, recognizing they can depress the respiratory drive, which counteracts our goal. Intercostal nerve blocks can be used for targeted relief.
And patient teaching is vital.
Crucially, the nurse must provide vigorous patient teaching. Encouraging incentive spirometry, deep breathing and coughing despite the pain is absolutely vital to prevent those secondary pulmonary complications.
And the most debilitating structural injury is flail chest.
Flail chest involves multiple rib fractures in 2 or more sites, which creates a free-floating segment of the chest wall. This segment exhibits paradoxical movement, sucking in on inspiration and bulging out on expiration, which makes effective ventilation impossible.
And treatment is supportive.
Treatment requires internal stabilization via PEEP and mechanical ventilation, humidified oxygen, careful fluid management to avoid edema, and again, meticulous pain control.
Let's transition to pulmonary embolism, PE, the textbook example of high VQ dead space. This blockage of the pulmonary arteries, most commonly by a DVT, presents a huge diagnostic challenge.
PE is the master of disguise. While the classic triad dyspnea, chest pain, hemoptysis is rare, the nurse should suspect PE in any patient with sudden, unexplained dyspnea, anxiety, mild hypoxemia, and that common finding of a low PACO due to reflexive hyperventilation.
And diagnosis relies on imaging.
Diagnosis relies on a high clinical suspicion combined with an elevated D-dimer, a CT pulmonary angiogram, or CTPA being the gold standard, and often a VQ scan if CT is contraindicated.
When a PE is suspected, what are the immediate acute nursing interventions to stabilize the patient?
Stabilization has to happen immediately while diagnostics are pending. We position the patient upright to facilitate breathing. We apply high-flow oxygen, usually a non-rebreather mask, aiming to maintain SPROs at 90% or greater.
And what about hemodynamics?
Hemodynamically, we support the blood pressure. If the PE is massive, the right heart can fail, leading to obstructive shock. 4V fluids might be used cautiously, but often vasopressors are required to maintain systemic pressure, as aggressive fluids can further strain the struggling right ventricle.
Pharmacologically, what is the mainstay of treatment, and what's the nurse's role in managing the risk associated with these medications?
Anticoagulation is the treatment mainstay. It's often started immediately with IV unfractionated heparin for rapid effect, titrated based on PTT, or a low molecular weight heparin. Warfarin, or DOACs, are used for long-term therapy, overlapping with heparin until the INR is therapeutic.
And what about thrombolytics?
Thrombolytics, like Altiplas, are reserved for a massive PE with hemodynamic instability because of the high risk of catastrophic bleeding. The nurse's role during thrombolysis is intense. Continuous, meticulous monitoring for signs of bleeding, checking all orifices, IV sites, and neurological status for an intracerebral hemorrhage, and avoiding all unnecessary invasive procedures.
And prevention of recurrence is crucial. What is the non-negotiable patient education component?
The teaching centers on minimizing stasis and ensuring compliance. We emphasize medication adherence, the necessity of early ambulation, performing leg exercises every hour during long trips or bed rest, and maintaining hydration.
And teaching them what to look for.
Exactly. Teaching the patient to recognize signs of a DVT, unilateral leg swelling, pain, redness, and PE recurrent sudden dyspnea. Chest pain empowers them to seek help immediately.
Finally, in this section, let's briefly cover respiratory infections, focusing on the complications of pneumonia. The source differentiates community-acquired from hospital-acquired.
The nursing focus shifts quickly to complication identification. Pneumonia can lead to pleurisy, which is inflammation of the pleura, often causing a friction rub, or a pleural effusion, which is fluid accumulation.
And that fluid can get infected.
If that fluid becomes purulent, an empyema, it requires immediate, often surgical drainage and specific antibiotic management. This necessitates the placement and maintenance of a chest tube.
And what about systemic spread?
Other major complications include atelectasis and, critically, the risk of systemic infection. The source specifically notes the risk of meningitis, especially with S. pneumonia. If a patient with pneumonia suddenly develops a fever, neck stiffness, and severe confusion, the nurse has to immediately prepare them for a lumbar puncture to rule out CNS infection.
We also have a quick overview of thoracic surgery, lobectomy, pneumonectomy, and so on. The nursing care plan post-op has to reflect the specific procedure performed.
It does. Post-op management relies heavily on pain control, promoting pulmonary hygiene and managing the chest drainage system. For most procedures, like a lobectomy or a resection, chest tubes are essential to remove air and fluid and re-expand the remaining lung tissue.
But there's a key exception.
The Q exception is the pneumonectomy, which is the removal of an entire lung. In this case, no chest tubes are generally left because the goal is for fluid to fill that empty space gradually to prevent a mediastinal shift. Understanding this specific goal is absolutely essential for the nurse managing the post-pneumonectomy client.
We've used ABGs extensively throughout this, so let's end this deep dive by addressing the physiology behind those numbers. Acid-base regulation. The body maintains that really narrow pH range of 7.35 to 7.45 using three mechanisms of control.
And the three systems operate with vastly different time signatures. First, you have the buffer systems, the immediate chemical response. The most important extracellular buffer is the carbonic acid bicarbonate system. Buffers change strong acids into weaker ones instantaneously to minimize pH swings until the excretion systems can catch up.
And the key relationship is lungs and kidneys.
The key functional relationship for the clinician is that the lungs control the volatile acid, which is CRO, and the kidneys control the fixed base, which is bicarbonate or HCO.
And the respiratory system is the rapid response team. It's effective within minutes.
That's right. The lungs manage CRO. If the body is acidotic, the respiratory rate increases hyperventilation to rapidly blow off CROs, lowering the acid component and raising the pH.
And if it's alkalotic?
If the body is alkalotic, the rate slows hypoventilation to retain GO-Uro, lowering the pH. This is a very fast but limited compensatory mechanism. Sustained hyperventilation leads to fatigue, and hypoventilation is limited by the body's need for oxygen.
And then we have the renal system, the permanent fixers, but also the slowest.
The kidneys provide the powerful long-term solution. They take hours to days to fully activate, but their work is permanent. They respond to acidosis by conserving or generating new bicarbonate and simultaneously eliminating excess hydrogen ions by secreting them into the urine.
And in alkalosis, they dump bicarb.
In alkalosis, they increase bicarbonate excretion. This is why in chronic respiratory acidosis, like in long-standing COPD, the patient's bicarbonate level will be chronically elevated. The kidneys have fully compensated over time.
For our advanced listener, simply reciting the four imbalances is insufficient. Let's discuss how to interpret complex mixed disorders by integrating the anion gap.
The anion gap, or AG, is absolutely essential when you're analyzing metabolic acidosis. Metabolic acidosis is defined by a low pH and a low bicarb. The anion gap helps us determine the cause of that acidosis. The formula is sodium minus chloride plus bicarb. Normal is typically 8 to 12.
So what does a high anion gap tell you?
If the patient has metabolic acidosis with an elevated anion gap, so greater than 12, it means they've added a new acid into the system like lactic acid from shock, keto acids from DKA or starvation, toxins, or renal failure.
And a normal anion gap.
If the patient has metabolic acidosis with a normal anion gap, it usually means they have lost bicarbonate, the base, either via the GI tract from severe diarrhea or via the kidneys. This is then compensated by increased chloride retention, which is why it's also called a hyperchloremic acidosis.
So it's a crucial diagnostic step.
It's crucial for initiating the correct treatment. Do you need to stop acid production, or do you need to replace lost base?
And let's quickly touch on the concept of mixed disorders, which are so common in critical care. A patient rarely has one pure disorder.
Exactly. I mean, take, for example, a patient with severe COPD. So they have chronic respiratory acidosis, who then develops a gastrointestinal bleed and requires massive gastric suctioning, which causes a metabolic alkalosis. Their ABG might show a near normal pH because the two primary disorders are partially canceling each other out, even though the patient is profoundly ill.
So how do you spot a mixed disorder?
The advanced interpretation rule here is this. If both the respiratory parameter, the PICO, and the metabolic parameter, the HCO, are abnormal, and neither one fully explains the deviation of the TH, the patient has a mixed disorder.
Can you give an example?
Sure. If the pH is 7.2, so very acidic, but the PICO is 60, which is a respiratory acidosis, any of the bicarb is 15, which is a metabolic acidosis, both systems are contributing to the acidity. That signals a dire situation demanding simultaneous intervention for both causes. Reading ABGs is a comprehensive clinical correlation, not just a math exercise. #tagout.
This deep dive into advanced respiratory care has been comprehensive. We've moved from the physical assessment differentiating the specific timing and quality of adventitious sounds all the way through to the nuanced management of complex life-threatening syndromes. We saw the immense value of anticipatory nursing, from using ETCOS as an early warning for ventilatory depression, to meticulously maintaining the VAP bundle and performing high-stakes tasks like proning. The distinction between failure to oxygenate and failure to ventilate, it really dictates every single intervention.
It really does. And if we revisit that delicate balance of gas exchange, the subtle complexity of diffusion limitation stands out as a powerful reminder of pulmonary reserve. While a thickened alveolar capillary membrane might provide enough time for oxygen to diffuse at rest,
Things change under stress.
the source stresses that during exercise, when cardiac output dramatically increases, the red blood cells spend only about a third of the time they usually would in the capillary bed. It's at this moment, when the demand is high and the transit time is short, that diffusion limitation becomes clinically apparent, resulting in profound exercise-induced hypoxemia. This subtle physiological mechanism is a powerful reminder that reserve capacity is the first thing to fail when a patient's metabolic demand increases.
That concept of invisible, powerful reserve capacity is fascinating. So here's a final provocative thought for you to chew on until the next deep dive. Considering the fact that in a trauma patient, the initial hyperventilation response to hypoxemia may temporarily mask the severity of their impending shock, what other physiological lies or compensatory mechanisms are actively at work in your body right now, like the slow, powerful, unseen renal compensation that could be hiding critical information about your system's underlying state? Think about the systems working in the background that you only notice when they fail. We'll talk to you next time.